I'm really happy at this point to shift the discussion to a group panel that will be talking about prioritizing research needs for Asian medicine. And I view this as a really important outcome of this talk. We've gained so much new information, and we've also gained a lot of ideas about integration of these different health models with Western medicine and how to test some of those different strategies. So without further ado, I want to turn things over to Dr. Lin and start the panel discussion.
Great. Thank you so much, Dr. Stafford. And again, great congratulations to you, the other co-chairs and the organizers of this really fantastic jam-packed conference. Please welcome the three co-chairs, Dr. Randy Stafford from Stanford, Dr. Neeta Gautam, Dr. Ying Lu, and also Dr. Jun Mao will be joining from Memorial Sloan Kettering. I'd love to start with a discussion about your top priorities and then move on to a structure of evidence, safety, effectiveness, quality, and trust, and talk about that. So we'll have a brief time for that. Oh, and Dr. Pathak, I'm sorry, will be joining us as well. So thanks to Dr. Pathak as well for joining the panel. But perhaps if we can start with Dr. Stafford, if you can tell us a brief, summary of your impression of the conference takeaways and what your top priority is for improving traditional Asian medicine evidence.
Well, we have heard so much during this conference, and I think it was really enlightening to focus on the issue of mental health today. This is an area that in some ways is a worldwide problem that contributes to a devastating extent to disability and loss of quality of life, quality adjusted life years. And I think it's a set of conditions that we need to take more seriously and face up to the fact that these are common conditions, particularly in modern society. You know, there are so many things and so many different strategies that we've talked about in terms of research. It's hard to pick out just one. But let me try to focus in on one thing that I am a true believer in. And I think this applies both to Western medicine as well as to traditional Asian medicine. And that's the idea of the comparative effectiveness clinical trial. And the idea here is that we're really trying to test different strategies in a real world setting to determine their effectiveness. That is, how well do they actually work in terms of alleviating symptoms or making people feel better. This has not caught on as much as I would like within the United States, and within the United States, clinical trials for medications are still very much focused on the idea that we're testing a new drug against placebo. What I think needs to happen more, even within drug research, is testing a new drug against the typical approved treatments for that condition. You know, whether we're talking about allergic rhinitis or depression or Alzheimer's disease. This is a big ask in some ways because those comparative effectiveness trials are more difficult to run and require larger sample sizes. But I think we need to apply the same idea to traditional Asian medicine. And what I'd like to propose is that this field move in the direction of these comparative effectiveness trials that include multiple arms. And I think in these trials, a placebo arm or a sham arm is probably the least important part of those trials. So for instance, a trial of sleep difficulties might have multiple arms that could cover herbal therapy and TCM, acupuncture from TCM, an Ayurvedic strategy for insomnia, a Western drug therapy for insomnia, and then perhaps other prevention-oriented Western models. This type of trial with multiple arms comparing effectiveness may give us the information we really need to sort out which of these therapies are working best. And also perhaps the idea that some therapies work best for some people, other therapies for others. So the idea of the comparative effectiveness trial, is my top priority.
Great. Thank you so much, Dr. Stafford, for those insights and observations. Perhaps we'll move to Dr. Pathak next for impressions of the conference and also top priorities, top takeaways.
Thank you for having me in the panel, and I have been very elated with the conference and Stanford's interest in traditional Asian health. And I feel that now that we are talking about what is the next steps that we can look at, there is one idea that can take further Dr. Randy's idea to Dr. Stafford's idea, is to maybe create integrative clinics which are focused on the clinical problem, which actually have diverse modalities that are being offered to the patients directly, and that will become a big subset that can probably become a big foundation, a patient population on which we can run the comparative effectiveness trials, while having all the other patient factors that influence the outcome. They all can be considered methodically, and we can have the data for that possibly. And an academic institution like Stanford can, if that creates these kind of clinics, then it will really bring people together, and we will be in a problem solution mode with maximum ease. So that's one important next step, which I feel. And these are clinics that are done this way in India and also in China, I'm told, where they run integrative medicine centers together. And there is no reason as to why we should not be able to replicate those here now in the West as well, now that there are a lot of physicians who are trained in those countries available here as well. So that would be one of the key the key messages for the next steps. And of course, from Ayurveda as a whole, understanding Ayurveda as a whole with the entire expanse for health, that would be that could be a separate mandate, because managing diseases, preventing disorders, and promoting health, these are the three goals of Ayurveda. And how do we bring them back to the people is an important consideration that we can actually have a brainstorming session for. And I won't take any more time and move the panel on to the rest of the speakers. Thank you so much.
Great, thank you, Dr. Pathak, for that the insights and bringing other experience to play. Let's go to Dr. Gautam about your insights for just impressions of the conference, takeaways, but specifically top priorities for traditional Asian medicine.
Thank you, Dr. Lin. For me, what I learned and kept coming back to was this constant reminder that the treatments need to be individualized, and that we really need to think about the individual who has the condition as opposed to the condition, and just treating that as, and that context of how that disease is manifesting in that person, and how do we address their illness in their context. And so we saw this come up in a variety of talks from Dr. Suraj and Dr. Pathak on day one about, Dr. Kong's talk about how not everyone responds to acupuncture, and how do we determine who are the best responders, looking at understanding just from Dr. Rao's talk about there are different types of dementia, and how do we identify those different types, because that identification can make a difference in terms of how we treat it and the outcomes, and really moving towards being more individualized in our treatment. And we see this corollary in Western medicine with this rise in precision medicine and looking at the individual genetics and the pharmacodynamics of an individual in terms of tailoring drug therapy, but that we could think about that in the context of the whole person. And really, my interest would be in terms of how do we move that forward? How do we bring all of this together so we're bringing the best of what all these systems have to offer in terms of providing care to our patients in the appropriate context.
Great. Thank you so much, Gautam, Dr. Gautam, for that excellent summary of the conference and the outstanding findings and opinions from our guest speakers. I'd like to go on to Dr. Jun Mao from Memorial Sloan Kettering. What are your takeaways from the conference and priorities for traditional medicine?
I want to thank Dr. Stafford and all of you for organizing this really exciting conference and creating the opportunity to bring the East and West together to create dialogues about this important topic. I think I actually am going to be a hybrid between Dr. Stafford and Dr. Gautam. I work in the Cancer Center. The modern oncology is moving towards precision medicine. And traditional Chinese medicine, Ayurvedic medicine, ancient precision medicine based on individualist care. I think the technology is here, the clinical trial methods are here, the doing large population-based research is here. So we have a lot of forces that create an opportunity for us to begin to studying exactly what the targets or phenotypes of mental health issues, or in my setting is a cancer symptom control, pain control. So because traditional clinical trial method consider everybody is one homogeneous population, you compare two populations, you make a claim one method is better than the other. We all know as physicians, that's not the truth, right? So if that's the case, we won't have a lot of very difficult case to treat. You don't even need a physician. So I think the time is here. We just need to dare to innovate, but also challenge us to be incredibly rigorous, to use the modern methods, research design and statistical method to provide robust research evidence. Because just saying individualist care is great, and I think the people here believe it, but there are a lot of critics of Eastern medicine. I think it's when we show the data in peer-reviewed journals and our critics become our friends. So I really want to encourage us to continue this dialogue and take the momentum from this conference and keep collaborating across the globe to move this field forward. So thank you for allowing me to be part of this panel.
Great, thank you, Dr. Mao. A wonderful message of daring to innovate, but also overcoming skepticism with evidence. And let's move on to Dr. Ying Lu, last but not least. Please, Dr. Lu, what's your overall impression of the conference and key takeaways as well as priorities for traditional medicine?
Thank you, Bryant. And also I just want to follow esteemed colleagues and to really congratulate the successful conference. I want to take over from Dr. Ma's comments that it's a critical issue about how to build, not only treat individual patients, but also how to collectively create evidence to support these traditional approach that really precise approach to individual patients. Here we have to realize there are also the physician effects may be very different too. And I know there was a very interesting trial done by Beijing China Academy of Chinese Medicine Sciences on insomnia. And they did really very rigorous randomization trial to send patients to be seen by 3 physicians. And then all the patients being seen by 3 physicians, and 3 physicians give the formula prescription, but the pharmacy actually did the randomization. So each patient either receive a placebo or the one of the drug from the one of the doctor through 12 weeks treatment. And the medication never be the same. All the physicians use different treatments, and the patient also, the prescription changes over the time. At the end of the trial, when they unblind the data, the results was all the physician performed much better than the patient received control drug, which is also herbal formula, but not particular for the insomnia. And also, interestingly, the physician variation is there. So it's only one physician that outperformed than the two. Even the two is better than placebo. They are not as good as the top physician. So that also a very interesting phenomenon that not only the drug is individualized, but also depend on who provide it. So I think it's critical that I really like all these suggestions. I think technology is there, but we need to organize in a structure, sorry for the light, that really organize together to set foundation to do this kind of study. In addition to clinical trials, there are also FDA recently start to focus on the real world evidence data. And to do that, the real world evidence will, I think, particularly suitable for traditional Asian medicine, because not only the modality is broad, the indication, the endpoint may be broad too. And so if we can do this kind of well-controlled, prospectively planned study in the real world evidence, embedded with trials, we will be able to answer a lot of questions, in particular what you mentioned about who will be the, what is the right treatment for right patient. And also we have this kind of statistic tool that we can actually do adaptive optimization for adaptation in order to do the comparison. So I really like what Dr. Ma said, the technology is there. It's the time that we need to put a will and really put together to put a multidisciplinary team to push forward of this field. Thank you.
Great. Thank you, Dr. Lu. And leading off of that, we need more evidence. I mean, everybody's saying basically we need more evidence, we need better evidence. How do we expand the number of trials that we conduct? How do we get more sample size? And also, do we have strategies for perhaps combining different studies together, harmonized meta-analyses, other techniques? I'm just going to throw this out there. I know we have limited time and so many questions.
Well, I wanted to be, kind of a little provocative here. And at least if we look at some of the literature that Dr. Lau Lixing reviewed, in some ways, the problem isn't necessarily a lack of studies, but the problem is really a lack of adequate quality studies. And I think that one of the messages I've taken away from the conference is that we have an enormous way to go in terms of standardizing and making sure that studies are designed appropriately, and also when published that they include the necessary information on design, intervention, and outcomes.
And what's the root issue of the quality? I mean, so we have to get the quality, but we still need to get, even with a quality study, we still need to get the sizes. As we've seen in Western medicine, you can do small, high quality studies, but you get very different results if you have a giant high quality study. So maybe Dr. Lu, from your statistical background, can you comment on that?
Well, I think some of the quality studies are out there, but there's a huge variations. There are a lot of trials done in China, and early days there's some quality controls because lack of training and infrastructure. I think those quality are being improved. There's other basic questions that not clearly, for example, most Western trials have been negative for some of the common practice that being shown positive in China. And partially the protocol are not comparable. For example, acupuncture in Western country, because insurance only pay very few times of the acupuncture. And so the frequency, what they use in the West trial is very different from the frequency they use in China. And the intensity in China is not possible here because of the cultural difference or the actual practice difference. So all these go to the very fundamental questions that I remember the one question in the session was, what is the dose-response relationship, right? What is the minimum dose? How long? What's the intensity, particularly if they have electronic stimulus, and how long do you need to move the needle? There are a lot of subtlety, and so by all these combinatory possibilities, you really need a lot of engagement from people. And the acceptance of Eastern medicine or Asian medicine in US, I don't think is in the organized way right now. So we see a lot of office around there, but these cannot be translated together into a trial because they are private practice. Most of them don't have electronic medical record system. So I think so we need to do a lot of fundamental work, possibly quickly, but that will generate a lot of possible things. I think the VA is moving on, but we hear today the VA's study. I know DOD has some trials about acupuncture. Those are large scale within healthcare system, can move quickly, but I don't know the herb medicine. I don't think that will be able to do very quickly. Still a long way to go.
Sorry, Dr. Pathak.
Yeah, so I wanted to, I've spent a lot of time wondering about what should be the right methodology to investigate traditional medicine, especially vis-a-vis Ayurveda. And I'm sure it applies to TCM as well. And there has been a lot of fundamental discussion, even in the statistical community, whether these models of P lesser than 0.05 showing clinical significance, whether those models, what do they really tell us? So what we need to identify is the question that we are asking to the clinics, and how are we quantifying the data itself? I believe that the American Statistical Institution in 2016 released a statement saying that P lesser than 0.05 is not the statistical significant, is not the radar through which we test the effectiveness. So what is it? I am not an expert in that direction, but I have pursued the conversation for a long time. Then if that is not the standard, then what is the methodology that we should use to test the effectiveness is the key question. And I believe that Dr. John Ioannidis at Stanford itself had published a paper on why most published research findings are false. And that was a very provocative study, but there has been a lot of alternative statistics conversation, which we should take into consideration for the brainstorming before we plan the next steps.
Great. Maybe I'll hand that. Oh, sorry, Dr. Gautam.
Briefly, just to say, I think Dr. Pathak brings up a great point about, as we talk about research and what is considered significant, that we are clear about definitions. I also wanted to call out the opportunity of partnering with our neighboring institutions, whether that's in China or India or in other countries, as ways to increase and bring up the research. That does bring into what Dr. Lu said about, being clear about what we mean by definitions, like for the example of the frequency of treatments. If we were to do a study both in here and in China, how do we come to a common understanding of what we're looking at? And then the other thing I wanted to bring up, and we see this in Western medical literature all the time, is that the research is out there and there are some really great findings, but the dissemination of that information is problematic. And it can take, and there have even been studies that shows it takes 15 years or more for studies in Western literature to become common practice. And so part of our conversation has to be also surveying the landscape and understanding what is already out there that we could be building from, that we're not building from zero, and acknowledging what's already come and taking that as our first steps.
Yes.
Would love to get a perspective from Dr. Mao, especially from the framework of oncology, regarding Dr. Pathak's comments of, statistical significance. I mean, there are other ways to look at it, in terms of number needed to treat, and obviously this, in the cancer world, mortality, and as well as, dose, Dr. Stafford's comment about, standardizing, Dr. Lu, standardizing doses. How do we compare? How do we do studies with, doses and treatments kind of all over the map? So would love to hear your thoughts on the discussion, Dr. Mao.
I do think we need to both respect the clinical authenticity of the practice as well as the rigor of research methods. If you don't pay attention to either, you're going to get negative trials. You're also going to get study poorly done. So I find the quality, the study in China, our group do a lot of herbal systematic review to inform our research in the US. A lot of the studies in China, even the outcome are not validated outcome. It's really just a clinician rate. And then when you don't have blinding, that is just full of bias, right? So then how do you convince other colleagues to believe there's any truth? You know, especially we're not convincing the people already believe it, we're convincing the skeptics, right? So I think that those are the really important method questions. I do encourage, we at the West who know the study method to really collaborate our East. I do think colleagues in China, India are eager to learn. It's not like they want to do bad study, it's just they didn't know. So I think only by collaboration. And I also want to emphasize there's a lot we can learn from them about the clinical wisdom. For example, MSK, we're learning from our Chinese colleagues application of Chinese herbs to manage symptoms begin to apply in the US setting and seeing pretty good promising clinical effects. And then once that observation can be more of a clinical gut and be standardized, then that's where we design trials. So I do think it's a bilateral process. And I do think in the area of oncology acupuncture, I'm currently I'm the chair for the American Society of Clinical Oncology in collaboration with the chair of palliative care in MD Anderson to develop the ASCO clinical guidelines for integrative treatments for pain in cancer patients. So that does get into just doing the research is not enough. We have to translate the research finding into evidence and get it into the clinic and teach our oncologists and oncology nurses and hopefully eventually get insurance coverage. I do think the reason we do research is to help patients, right? To get your CV longer is one of the goals, but it's not the ultimate goals. So I do think I feel like there is hope. At least I think conferences like this are incredibly important. I do encourage Dr. Stafford. I know you are leading a paper. I do think it's important to work with colleagues to identify what are the 3 to 5 top priorities we should focus. If we all scatter energy on various diseases, various outcomes, do a lot of small interventions are very unique, but there's nothing to combine, we're not going to move the needles very fast. I think if we have 3 or 4 major herbals or major Ayurvedic or TCM interventions showing in large trial context addressing major public health issues affecting both the East and the West, we have some winners, right? I think, I don't know about India. I know for sure China is spending a lot of resources in TCM research. And I do think US need to do better, but and I do think the Patient-Centered Outcome Research Institute is embracing this comparative effectiveness research. We currently have 2 active trials funded by that organization studying acupuncture compared with standard medical treatment in oncology settings. So I do think things like this will help to move us forward, but as a field, we need to be more focused. If we are too scattered, we're not going to really reach very quick success. So I do think this is a conference really create that dialogue, and hopefully we take the momentum from here to the next step to some concrete goals and actions.
Well, there's so much to unpack from your insightful comments. I'm going to unpack part of that and hand it to Dr. Stafford, who also has too long of a CV. He doesn't need a longer CV, but he's doing this for patients. Dr. Stafford, Dr. Mao was talking about, the outcomes have not been validated, and we had talked about measuring effectiveness. So what more is to be done? And Dr. Mao also talked about focus. Should part of the focus be on developing just in a few areas some standardized, validated outcome measures? What are your thoughts on that? And then I wanted to get back to, because I know we have a very short time, a comment, and then I'll open it up to the group about, what are the top strategic focuses that should be done. I think that's a great strategic idea.
I very much agree with the concept that focusing our energy on certain key issues and key conditions really is the only way we're going to make a difference. I think you're absolutely right that there's a great propensity to try to cover the whole territory, and in doing so, kind of spread the collective effort much too thin. So, in my mind, we need to continue to focus perhaps on those conditions where we know that Western medicine doesn't do a very good job, and where there is evidence that alternatives may well be as effective or could be combined with Western strategies in a way to truly improve the health of the public. I think that this issue of skepticism is going to be a really important one to overcome. And I think that one interpretation of Dr. Mao's comments is essentially, bad studies are worse for credibility than no studies. And I think we really need to focus this idea of thinking about all the components of good study design, just, basically defining the population well, defining the intervention, defining a reasonable comparison group or multiple things that are going to get compared. Also really focusing on outcomes. And I think that this idea of measurability in some ways is a concept that's much more central to Western science. But I think as we move forward in a sort of global economy and global health system, we need to think about that, the importance of that measurability aspect, even applied to systems and to health belief models that haven't at their root kind of embraced measurability. So I think we're up against a lot of challenges here, but I agree that making Eastern medicine more credible is an important goal. And I'm going to do what I can to move that forward.
Great. Thank you, Dr. Stafford. I'm going to throw it back to Dr. Pathak. Areas of, as per Dr. Mao's suggestion, areas of strategic focus. Is this a disease framework? Is this a functional framework, a treatment framework? Like for Ayurvedic medicine, if you were to choose 2 or 3 areas to focus on where we really need to gather evidence, what would those be?
Well, the disease model is a good model because it keeps everything clean, because you have a clean diagnostics, you have set systems, everyone has certain expectations, and it's very neat. However, I feel that from my understanding and my work in Parkinson's disease, I realize that there's no one Parkinson's disease. I've done a very intensive study on it. Every patient is truly different, and the myriad of symptoms, the range of symptoms and presentations that spill over to the other neurodegenerative conditions that can exist. Also, in the aging population, and how do you differentiate bradykinesia of Parkinson's disease with aging? I feel that having an amorphous base that attracts a patient population would be a very good start, because through that we will be able to implement traditional wisdom in a very different way, and at the same time unearth other avenues for enhancing health very quickly. Because if we become very disease focused, we might lose out the opportunity of putting on this whole endeavor together. That is my feeling. And if we focus on neurodegenerative conditions, or if we are looking at cardiometabolic diseases, these are the 2 very significant areas where traditional medicine and traditional wisdom can impact. And now there is an emergent focus also on immunity, and that becomes too broad and too wide. But cardiometabolic and neurodegenerative areas, there's a definitive need where we can pool resources together and do focus clinics. Also oncology, and there's a lot of work, especially from Ayurveda, that exists out there, which we can quickly implement and build on, and we can see what's really working and what is not working. We can do in-house, we can do tests on that, on smaller populations, which are very well designed, because the experiments can be designed to finally have an all or none effect. So we know what truly is the factor that influences. But if we use those methodologies, we will be able to identify the wheat from the chaff, is my perception.
Great. Thank you, Dr. Pathak. I'm going to hand it over to Dr. Gautam as a fellow primary care provider, from the lens of chronic disease management, population health. What are the focus areas you think per Dr. Mao's suggestion, that could win over the world to traditional medicine?
So thank you, Dr. Lin. What I see a lot of in my practice, and I'm sure you do as well, Dr. Lin, is that so many of the conditions that we see and treat that come down to a common factor, which is around lifestyle and more specifically nutrition. And so my bias, my interest would be, looking at nutrition in the context of we're trying to get to the root cause of whatever the condition is. And so how could we utilize nutrition itself, fine tune that, individualize that, and branch out into a variety of conditions, as Dr. Stafford's fantastic presentation on day one about anti-inflammatory diets. And in Ayurveda, there's such an emphasis on the gut and that you are what you digest, that whole area of nutrition, which, in a standard Western medical training, we learn next to nothing about, but is such a rich area, and we could make a difference in so many conditions by getting down to the root causes. And so I'm almost going to call for maybe reframing it, instead of thinking about, do we talk about diabetes or do we talk about high blood pressure? Can we talk about learning frameworks or structures under which we could individualize nutrition recommendations, or recommendations around daily routines and habits and sleep cycles and all of those kinds of things, and show that would make a difference in so many of the conditions that we see day in and day out.
Thank you, Dr. Gautam. Would love to get the statistical model data perspective from Dr. Lu. Is part of the pathway to convincing the world about traditional medicine, is it also creating trust for new methods, new statistical methods, new data methods, to really analyze the data in these trials that can be very different with non-standard doses, and perhaps effectiveness assessments that are done in a different way? Thoughts on that, Dr. Lu?
Thank you. I think the statistician can help, particularly in the design, the study, and the trust is really in the design, that you're trying to account for potential bias. And as Dr. Mao mentioned, right, one of these, remove the unbiased, the investigator cannot be need to be blinded, and also not be the one that valid endpoints. And there are also a lot of data methods available now, and I think one thing that statisticians and data science can help is to build a real database to capture the population data. For example, as I mentioned, as the day one example, right? The China, they used the mobile device to build a registry for COVID-19 quarantine population. And then they didn't do the extensive data survey at the time because the emergency situation, right? It was not well designed, but it gave the idea that potentially we can build our cohort population like Apple Heart Study through mobile device, but we record not only their health status, but also their use of, the herb medicine, nutrition, CTM therapy, or Ayurveda therapy, something that we can track, build a longitudinal cohort, and that will help us learn a lot. I mean, these kind of things can be targeted or can be non-targeted, generic. And but of course, people will be willing to share. The other part important now, the ICD, US is using ICD-10 in the hospital system, but in China and the other parts, they start to use ICD-11, and ICD-11 actually contain the traditional medicine code, so that can be integrated into healthcare system records, and potentially also will help us to build reliable information. As long as we have systematic approach and the data is reliable, then there are a lot of analytical tool is not the problem. The problem is that we need to get the right data, unbiased data, and systematic data.
Great. Thank you, Dr. Lu. We've gone over our time, but I want to end on one area that the panelists have been chatting about is safety. So I'll throw it back to Dr. Mao regarding safety. As all these treatments can have a lot of different ingredients, very unlike Western medicine, which is very, distilled down to the active ingredient. How do we assess safety? How do we measure safety? How do we show safety? Dr. Mao.
I think in our clinical trials, we definitely need to assess safety the way how Western medicine clinical trials are. At least in my experience doing even acupuncture trial, there are definitely safety issues. It's not typically not major, but it's a mild to moderate. But I think a lot of trials I read, like say there's no safety. My gut feeling is that those are not collected rather than there's truly no safety issues. I think one of the things we need to confront our general field of complementary alternative medicine, traditional medicine, is a lot of time we feel like if we say anything bad about our field, whether it's ineffective, their safety issue, we are beating down our field. I think we need to just get past that. Yeah. I think if we can truly say what is working, what is not working, for what type of patients you need to be careful is safe and not safe, we're going to move the field so much more forward and also get the buy-ins from our conventional medicine colleagues, at least in the area of oncology. I think when we approach herbal medicine with such a rigor, we actually earn a lot of respect from our colleagues, and they keep referring patients to us because they know we don't just throw any herbs at them. We really look at drug-herb interaction and trying to pick herbs don't have anticoagulant effects and stuff when people already are prone for bleeding risk and stuff. So I do think we need to just to get rid of our thinking is, because it's natural, it's safe. If we say anything is unsafe, we're shaming our field. I think we need to really just get over that hump and do that in our clinical practice as well as research. So thank you for that great questions. I think it's really important.
Great, well, thank you. And we're way over our discussion time, so I'm going to close it here. As co-director of the Center for Asian Health Research and Education, I would really want to thank the co-chairs, Dr. Randall Stafford, Dr. Neeta Gautam, and Dr. Ying Lu for organizing this fantastic conference. Really great thanks to Shannon Judd, Chloe Salas, Sally Lee, and the whole Stanford video conference team for throwing a seamless conference. And really great thanks to the speakers and the panelists today, and most thanks to the attendees. This conference was developed for the attendees to disseminate this important information.